Today we're going to talk about nursing care of persons with obsessions and compulsions and other related disorders. Our objectives today, after this lecture, you'll be able to discuss the role of obsessions and compulsions in mental disorders, apply the nursing process with recovery-oriented interventions for persons with obsessive compulsive disorders, and differentiate between other obsessive compulsive disorders. So most of us experience times when we're preoccupied with a specific thought or idea. I know that I get a little preoccupied sometimes with things being neat on my desk or wanting things to be a certain way or making sure that all the pictures on the wall are hung straight. But for some people, this becomes a problem when it interferes with their daily lives. Many also find that routines and rituals are important in organizing our work and home life. That is true for all of us. When these preoccupations and rituals interfere with our daily life, then they become abnormal and they may represent symptoms of a mental disorder. So we're going to talk about obsessive compulsive disorder. What are obsessions? So breaking down what this disorder actually means. Obsessions are excessive, unwanted, intrusive, and persistent thoughts or impulses or images that cause anxiety and distress. It's something that is not under the person's control, and it's not incongruent with patients' usual thought patterns. It could be like things that they wouldn't normally think about. This includes fear of contamination, pathological doubts, need for symmetry and completion, thoughts of hurting someone, thoughts of sexual images. So what is a compulsion? So if obsessions are all those thoughts that are intrusive and there's something that they're constantly thinking about, the compulsion aspect of it is acting on those thoughts. So it's repeatedly performed behaviors in a ritualistic fashion, and the goal is to prevent or relieve the anxiety and distress that's caused by the obsession. Common compulsions are hand washing, excessive cleaning, checking on things, arranging and rearranging things, counting, ordering, and hoarding. If someone has an obsessive thought that they need to turn the light on and off 10 times, and that's all they can think about, it's so intrusive that it's disrupting their schoolwork or their work in the office. Nothing is going to make that obsession thought go away until they do the compulsion of going over and actually turning that light on and off 10 times. So as you can see here, we start with the obsession. It's that repetitive, unwanted thought or image or urge. It causes great distress. Then they have this compulsion. It's a behavior that repeatedly performs to reduce that distress, and then they feel some temporary relief. So the compulsion makes them feel better for a little while, and it reduces their anxiety. The goals with therapy for people with OCD is to break this cycle. The average onset of OCD is pre-adolescence, but can occur in early 20s to mid-30s, as most mental health challenges do, with symptoms often beginning in childhood. It's a gradual symptom onset. It gets worse with age. Men seem to be affected more often as children and most commonly are affected by the obsessions. Women have a higher incidence of checking and cleaning rituals, with onset typically in their early 20s. The most common obsession is fear of contamination. Many use dissociation as a defense mechanism, and this is characterized by episodes of symptom diminution and exacerbation. So it kind of comes and goes. What brings it on could be a stressful event, or maybe if it has to do with something in their home, if they are expecting to have a house party soon, it can bring on obsessive compulsive cleaning habits. So predictors of poor outcomes include initial symptom onset during childhood, severe symptoms, long duration of illness, and male gender. So for the clinical course, this creates tremendous anxiety for the patient. Individuals perform the compulsions to relieve the anxiety temporarily. Compulsions often are recognized as odd or strange to the individual. So they know that what they're doing is odd or strange perceived by other people, but they still have to do it anyways. They might attempt to resist doing the compulsion, but eventually the repetitive behaviors are included in their daily routines. Maybe sometimes they'll do it nonchalantly so people won't notice. So the patient usually has recognition that thoughts and actions are unreasonable or excessive. The thoughts and rituals cause severe disturbance in their daily routines, relationships, or occupational function. They're time consuming and clearly exceed cultural or religious norms. Thoughts or behaviors not a result of the presence of substance or medical condition. So if this only happens during times when they're abusing substances, then it's not included for diagnostic criteria. So obsessions can be aggressive acts against themselves or others as well. They can also be religious obsessions. With some compulsions, rituals are common. This consumes a great deal of time to complete. Sometimes they can think magically and perform compulsive acts. Hoarders check their belongings repeatedly sometimes to ensure nothing is missing. In children and adolescents, because children subscribe to myths, superstitions, and magical thinking already, obsessive ritualistic behaviors may go unnoticed for a long time. Typically, parents notice the child's grades begin to fall as a result of decreased concentration, usually because they're so preoccupied with their thoughts, their obsessions, and great amounts of time are spent performing their rituals. OCD typically manifests in childhood in the second decade of life, so in their 20s, and can be a lifelong illness lasting more than 30 years because it does diminish over time. Adults have an early onset, possible lifelong and debilitating condition. It's linked to higher rates of depression, poorer mental and social functioning. Elderly are more thought disturbances and common communication difficulties. This seldom begins later in life. So if this is something that happens after the age of 50, then other things need to be excluded, like neurologic diseases. As far as family response to the disorder, the severity of symptoms is really going to predict the family's distress and response to this. The assessment will reveal the amount of education and support that'll be needed for the families. Family members are experts in the individual's severity of illness, and they will be the ones to notice subtle changes. Particularly, the people who are experiencing OCD are likely to downplay how often that it happens and how often they may perform their rituals. So, family members are really important and critical in knowing when they're having an exacerbation of their symptoms and like noticing that they're doing them more often than they might admit. So discussing with the family how they will adapt to the changes, referring them to social services as needed for additional assistance. A family member is the best individual for the nurse to question about any changes in the patient's compulsive actions. So working towards recovery, OCD is treated with medications such as maybe SSRIs to kind of reduce those anxiety driven compulsions, and then cognitive behavioral therapy, supportive therapy, electroconvulsive therapy may be considered in extreme cases. Um, Transcranial magnetic stimulation, which is what you see in the picture here, psychosurgery in extreme cases, or deep brain stimulation in extreme cases, but both of those are rare. Nurses' therapeutic communication and interpersonal skills are crucial for these patients. Intervention should focus on physical consequences and psychosocial aspects, maintaining skin integrity, especially if this is someone who's like hand washing a lot. We want to pay attention to their skin condition, encourage tepid water, and make sure that they're not using burning hot water. Encourage hand cream and moisturizing soaps. Maybe help them come up with a time schedule, or maybe time limited washing would be appropriate. One thing we do not want to do is we do not want to restrict them when they first come in inpatient from doing their rituals. So when someone comes in as an inpatient and they have OCD, we will allow them, as long as they're not hurting themselves or others, to complete their compulsions, their rituals, to help relieve that anxiety so they're not so keyed up all the time that they'd be unwilling or unable to receive new education and support. Exposure and response prevention, we want to know what those triggers are and maybe expose them to the triggers and ask them to refrain from performing the rituals. This would be easiest with someone who has a contamination fear and feels the need to, maybe use hand sanitizer, wash their hands, or has like germophobia. Expose them to a trigger that would normally cause them to wash their hands right away afterwards, and then ask them maybe to refrain from performing that ritual and see if they can manage that. Of course, after some therapy and some discussion and some preparedness. Use thought stopping techniques during that time where they would say to themselves, stop, when obsessional thoughts happen. And that may sound really silly and simple, but it actually does help if they can just tell themselves, stop, I don't want to think this anymore, I just need to stop. The medications, again, SSRIs, would be very helpful in reducing anxiety long term. Um, any other antidepressants, occasionally antipsychotics. They have a questionable effect, but sometimes given at low doses can be effective, but they would trial them for at least 8 weeks before deciding if the risks and the benefits, if the risks outweigh the benefits. Trying some relaxation techniques, improving their sleep patterns. This may help decrease their anxiety. Maybe some cognitive restructuring, like altering the way they think or the way they perceive a situation to help reduce their stress. Alter immediate dysfunctional appraisal of a situation and the perception of long-term consequences. Bring down those stressful thoughts around those triggers. And then analyze their thoughts versus reality if they're having any of that magical thinking. Interventions for inpatients, so carefully and clearly explain the unit routines, assess and monitor level of anxiety and disability, monitor for psychiatric comorbidities and suicide risk. Initially, do not prevent the rituals. Remember, we want to let them do their rituals so it reduces their anxiety so they're able to learn and take in new information and just be susceptible to therapy. Recognize the significance of rituals and empathize with the person's needs. Inpatient focused care is really challenging due to the time factor and ritual requirements. We only have so much time in a day to work with each patient, but we're going to help them as needed with their ADLs, monitoring the medication effects, group teaching, making sure they have adequate calorie intake, and individual counseling. Sometimes this is found in the emergency setting. They may seek care for other problems before their OCD is found out, and this could include, having excoriated skin from raw hands from overhand washing or burns. So early recognition of symptoms and referral to help is very important. Family interventions, education is always needed, assistance in monitoring symptoms and interventions, and include the caregiver in the teaching sessions whenever possible so they can be really involved in the care. Community treatment, we have partial hospitalization and day programs that are really helpful. Daily outpatient treatment would be ideal, and maintenance outpatient therapy, and maybe even home nursing visits. So other related disorders that are obsessive compulsive that I want to just touch on, this one's trichotillomania. This is a chronic self-destructive hair pulling that results in notable hair loss. The individual has an increase in tension immediately after pulling the hair out, so they feel a sense of relief. Sometimes they ingest the hair, and this may lead to anorexia and stomach pain, anemia and intestinal obstruction and peritonitis due to the bolus of hair in their stomach. Other medical complications include infection at the hair pulling site. For some, they may have little conscious awareness that they're even doing this, and others may do this to regulate negative feelings. So this can include hair from the top of their head. It could be their eyebrows, their eyelashes, even the arm hairs. So any hair pulling kind of to have that pain to relieve the anxiety. Excoriation or skin picking disorder similarly helps relieve some of that anxiety. Repetitive and compulsive picking of the skin that causes damage. Most common areas are the face, arms, and hands. Most people use their fingers, but you may also find that they use tweezers or maybe even pins, and that could be push pins or a needle and thread kind of needle. This leads to significant distress. Treatment is pretty limited. It's similar to trichotillomania. They need some behavioral therapy. Some medications could be lamotrigine, it's a mood stabilizer, and that can help just reduce their anxiety and get them, able to cope better with whatever situation is triggering them to feel the need to skin pick or pull out their hair. Next is body dysmorphic disorder. So this is when someone has a focus on a real but slight or an imagined defect in their appearance, and they have a preoccupation with this perceived defect that causes significant distress, and it interferes with social functioning. They avoid work and public situations altogether. It may affect their relationships, their peer relationships, or romantic relationships. They might seek surgical correction, but that does not correct whatever defect they seem to feel that they have. This can be extremely debilitating. This usually begins in adolescence and it continues throughout adulthood. And this is usually not actually seen in the psychiatric setting unless coexisting psychiatric disorders or family members insist on psychiatric attention. Part of the reason for that is plastic surgery offices are generally outpatient office settings outside of a hospital, away from psychiatric settings. And these are elective surgeries. So people go in, they pay money, and they get the work done. They don't necessarily have to have any kind of psychological screening before they have these plastic surgery procedures done. So really, unless the doctor feels the need to refer the patient to psychiatric services, it's unlikely that they would be seen for this condition unless someone refers them or they're seen for something else altogether. Hoarding disorder. With hoarding disorder, these people will have a difficult time parting with or discarding possessions, regardless of their actual value. And this can begin in childhood and it just gets worse with age. Sometimes different triggers and stressful life events can cause this to get worse as well, as they apply significant meaning to everything that they have. So over 50% have co-occurring depression or chronic anxiety, and this can pose a public health and safety risk to others, whether it's a risk to themselves or it's a risk to emergency personnel coming into the home. It could be a fire hazard. This is often found by home health nurses. Sometimes people come into the emergency room after they've had a fall or they had something fall on them, or perhaps they have pests or rodents in their homes, or just a wound that won't heal, or whatever they come into the emergency room for. They end up needing visiting nurse services. The visiting nurse comes in and they find that they are living in this kind of situation. The best therapy for them would be cognitive behavioral therapy and medication therapy, probably those SSRIs to try to keep those anxiety levels down and help them develop coping mechanisms so that they're able to part with some of their items. That cognitive behavioral therapy to help whatever triggered this hoarding to perceive those events differently, or maybe to even perceive their life in the home with things that they are hoarding in a different way. And that is the end of the PowerPoints for obsessive compulsive disorders and other obsessive compulsive disorders.